Hey, Peds crew. Today's a tough but powerful topic.
Mm,
We're stepping into a really sensitive space, pediatric end-of-life care. It's incredibly challenging dealing with this reality, but absolutely vital for us as future nurses to understand how to be there for these children and their families.
it really is. Approaching death, especially with a child, is just profoundly difficult for everyone involved. Our goal here, looking at this material, is to understand not just the clinical parts, but how to provide, truly compassionate and effective support when families are navigating their most vulnerable moments.
That's exactly what this deep dive is about. We've been exploring material focused on pediatric end-of-life nursing care, and our mission really is to distill the essential knowledge you need to approach this area with competence, empathy, and, well, immense heart.
Yeah, and we're going to unpack some key areas today. The absolute necessity of clear communication, how to prioritize comfort, the vital role of cultural sensitivity, and sort of navigating both the practical and the deeply emotional challenges that come with this work.
Okay, so let's start by just acknowledging the landscape itself. Facing death in pediatrics is thankfully less common than adult care, but it happens for complex reasons, everything from trauma to severe physiological conditions.
That's right. Looking at some data points, things like unintentional injuries, accidents, they're tragically leading causes across different childhood age groups. And for our youngest patients, infants, SUID, or sudden unexpected infant death is a significant concern, particularly, between 2 and 4 months old.
And it's a reminder that even our preventative measures, like the safe to sleep education, which has dramatically reduced SADs,
Harsh reduction.
or promoting safe sleep spaces, those are part of this larger picture of keeping children safe. But sometimes, despite our best efforts, we move into a different phase of care.
Precisely. And that's the fundamental shift, really, in pediatric end-of-life care. Our usual pediatric focus is relentlessly on treatment, cure, getting the child healthy and home.
Right, the entire mindset is geared towards recovery and growth. That's what we do.
Exactly. But with end-of-life care, the goal fundamentally changes. It shifts to promoting a peaceful, graceful death. The focus moves from trying to prevent death to ensuring comfort and centering the patient and family's needs through hospice care. It's about compassionate support, moving away from, say, aggressive, invasive interventions aimed at prolonging life,
hmm
towards interventions aimed at ensuring comfort and dignity in the time remaining.
So given that profound shift in goals, where do we even begin to build the foundation for this care? Reading through the material, it felt like communication was described as the absolute bedrock. What makes it so profoundly important in this specific setting?
It truly is the most crucial tool we have. As nurses, we spend the most time with the patient and family, right? We're in a unique position to understand the family unit, how they function, how much information they want to receive, which, can change day to day,
Sure.
their cognitive level, their understanding of the diagnosis, and where things are headed.
And securing that foundational piece, who is the legal guardian? Who's authorized to receive information and make decisions? That seems basic, but absolutely key.
Absolutely critical, right from admission. When we talk about family-centered care here, the communication must be incredibly tailored. It has to respect the family's cultural background in every single interaction.
And developmentally appropriate, which is huge when there are siblings involved. How do you talk about this immense event in a way a young child can grasp while also allowing them some semblance of, normal childhood experience alongside their sibling's illness?
And it must be compassionate, always.
Yeah.
Informative, giving details about the diagnosis and the dying process as the family desires. And this is key honest. We have to use concrete terms like death or dying.
Because those euphemisms, like gone to sleep, can be genuinely terrifying or confusing for a child, can't they?
Exactly. They can lead to significant anxiety. Now, this communication isn't just with the family, it's across the entire multidisciplinary team. The nurse's role as advocate and kind of the voice for the patient and family within the team is paramount.
So we're translating the family's wishes and the patient's status to the physicians, social workers, child life specialists, basically everyone involved.
Yes, in rounds, through charting, in one-on-one discussions, and ensuring everyone on the unit knows end-of-life care is the focus for this patient. It's vital for consistent care. There can also be nuances in communication when a dedicated hospice team is involved versus a standard hospital team, and understanding those differences is part of the nurse's role too.
Okay, so let's talk about those specialized support systems. Palliative care and hospice care. There's often a bit of a gray area or maybe confusion between them for people.
There definitely can be. Pediatric palliative care, or PPC, focuses primarily on symptom relief managing pain, shortness of breath, but also addressing the psychological, social, and spiritual needs to maintain the best possible quality of life. A really important distinction is that palliative care can be provided at any time during a life-threatening or terminal illness, even for years, potentially alongside curative treatments.
Oh, okay. So it's not just for the very end. It's more about managing the burden of the illness itself throughout the journey.
Exactly. Hospice care, on the other hand, is specifically end-of-life care. The goal here is explicitly promoting comfort, maximizing family involvement, and supporting a natural, graceful death. It means moving away from interventions that would prevent death and focusing solely on comfort measures. And hospice care can be provided in the hospital or often at home.
The material really emphasizes the specialized PPC team.
Yes, these teams are gold standard, really. They are multidisciplinary, typically including physicians, nurses, chaplains, psychologists, child life specialists, and social workers. They're specifically trained to provide that holistic support, including grief and bereavement care that often begins before the death and continues well into the family's grieving process.
And there's even a focused effort to educate nurses on this, like the EL and SC initiative you mentioned.
Right, the End-of-Life Nursing Education Consortium. Its aim is to ensure all nurses have foundational knowledge in palliative care so they can provide high-quality support during end-of-life scenarios, regardless of whether a specialized team is formally involved or not.
Let's look at some of those key roles on a palliative or hospice team beyond the nurse and physician. Pharmacy, nutrition, social work, chaplain, they all play a part, don't they?
Absolutely. Right, pharmacy ensures comfort meds are available and in appropriate forms, thinking about ease of administration. Nutrition helps ensure the child gets desired foods if they can still eat or want to eat. Social work steps in for the non-medical needs, navigating things like employer notifications, maybe helping with housing if the family is far from home,
Practical things, yeah.
crucial practical things. And chaplaincy addresses the vital spiritual and religious needs, which are often central for families.
Okay, here's where it gets really interesting and something that really stood out to me in the material. The child life specialist. Their role seems incredibly unique and powerful here.
They are absolutely indispensable in this context. Child life specialists are experts in child development and how children process information and stress. They provide age-appropriate activities and therapeutic play, not just for the patient, but critically for their siblings too.
They help create moments of normalcy, focus on the child's strengths, and relieve anxiety in such a difficult time.
Yes, and they use play and developmentally appropriate language to help children and siblings understand what is happening in a way they can actually process. They help them develop coping skills. I mean, imagine trying to explain the complexity of terminal illness and dying to a 5-year-old or a 10-year-old.
Right.
The child life specialist can bridge that gap through play and understanding, offering emotional support and even pain coping techniques.
That support for siblings feels especially vital. It's so easy for them to be overlooked, I imagine, in the intensity focused on the ill child.
It really is. Okay, so moving from team support to perhaps the most immediate concern for the patient,
Hmm.
prioritizing comfort, specifically pain management. The material highlights a really difficult truth here.
Yeah, that pediatric pain is often underrecognized and undertreated globally, despite managing pain being seen as a fundamental human right.
Uh-huh.
That is tough to read.
It's a significant ethical and clinical challenge. Pediatric pain is defined broadly, really. Any uncomfortable feeling preventing relaxation or rest. And crucially, it might look different than in an adult. Children might not verbalize pain in the same way we expect.
The material describes different types: acute, somatic, neuropathic, visceral, and it introduces that powerful concept of total pain. Can you explain that a bit?
Total pain is essential to grasp. It's not just the physical sensation. It's the interconnected psychological distress, the social isolation, the spiritual angst that all amplify the physical pain in a dying child. Addressing total pain means looking beyond just medication. Yeah.
So how do we assess pain in a child who might not be able to tell us using a number scale? That seems like a major hurdle.
Assessment requires really careful observation and, crucially, input. Vital signs and positioning offer clues, sure, but parent or caregiver input is critical. They know their child best. They're often the best judges of their child's comfort level.
And there are specific tools mentioned that can help structure that assessment.
Yes, tailored by age and developmental ability. There's NIPS for newborns, looking at facial expression, cry, breathing patterns, limb movement, alertness. Then FLACC for younger kids up to about 7, observing face, legs, activity, cry, consolability.
Okay.
The FACES scale for kids maybe age 3 and up, who can point to a face representing how they feel,
Mm.
and the VA-SOBs, the Visual Analog Scale Observer version, if a child is developmentally able to understand and use a 0 to 10 numerical scale.
Okay, so once we have an assessment, what about interventions? What tools do we have?
Well, it's typically a combination of medication and non-pharmacological approaches.
Mm.
While medication is key for managing the physical pain, alternative therapies are incredibly valuable, often involving the family directly.
Like massage for relaxation, maybe? Or relaxation therapy using music, holding, therapeutic positioning.
Exactly. And incorporating play therapy, quiet, distracting activities like puzzles or coloring, linking back to that child love focus again. Many pediatric hospitals also have a dedicated pain team, often led by anesthesiology specialists, whose expertise is solely focused on complex pain assessment and management protocols.
And when it comes to medication, the material makes a strong point about the route of administration, especially as a child approaches the end of life. That seemed important.
Absolutely. The least invasive route is always preferred to minimize distress and the number of tubes or lines. So topical creams, oral liquids as possible, IV if needed, but also maybe inhaled or rectal routes might be options.
Right.
To give the example of morphine sulfate, it can be given in several ways beyond 5E if that's not feasible or desired by the family, like buccally, absorbed in the cheek, or even via nebulizer sometimes. This focus on comfort even dictates how we give the medication.
Wow. That level of detail speaks volumes about prioritizing comfort and dignity. Okay, building on that idea of respecting the individual, let's talk about honoring beliefs, cultural and religious care.
This is profoundly important and can significantly influence decisions about pain management and palliative care choices. Families might not always volunteer this information easily, so we have to be comfortable gently inquiring about their preferences and beliefs.
And providing culturally competent care means actively listening to and incorporating those beliefs into the child's daily care plan, not just ticking a box.
Precisely. It's also important to be aware that, unfortunately, disparities exist. Some culturally diverse populations might have less access to or utilization of palliative care services. So our role is to ensure equitable, respectful care for everyone.
And being ready to facilitate specific religious or spiritual ceremonies at the bedside, maybe involving the hospital chaplain or spiritual care staff when appropriate.
Exactly. Okay, moving to another really challenging area. Navigating difficult conversations, particularly talking about death with children based on their developmental stage, and also understanding grief.
This feels incredibly daunting for new nurses. How do you even approach that conversation with a child or their siblings?
One clear piece of guidance from the material is to use concrete terms: death, dying, dead. Avoid those euphemisms we talked about earlier, like passed away or lost, which can cause confusion and anxiety, especially for younger children or siblings.
Makes sense. And a child's understanding of death is directly tied to their age and development, isn't it?
Exactly. The material outlines this developmental understanding pretty clearly.
Okay, like infants and toddlers have very little concept of death itself. Their primary fear is separation from caregivers.
Right. Preschoolers, maybe 3 to 5, they often see death as temporary or reversible, something that happens to others, maybe like in cartoons, not permanent.
Then children in early school age, say 6 to 12, they start to grasp that death is final and universal and that it can happen to them personally. It becomes more real.
Yes. And adolescents, they understand death logically, similar to adults, and comprehend its universality that everyone will eventually die. It's also really important to consider if a child has developmental delays that might impact their understanding, meaning we might need to keep our language simpler if needed.
And the impact on siblings that can be significant and long-lasting.
Yes, while many siblings adjust over time, especially if they receive support, others can experience ongoing difficulty, particularly after a sudden or unexpected death. Childhood traumatic grief is a real concern.
What does that look like?
It might manifest as changes in sleep or appetite, persistent sadness or anger, or maybe repetitive thoughts about the death. And this kind of grief can interfere with their ability to remember positive times or develop healthy coping strategies down the road.
And our role in family-centered care extends to supporting those siblings developmentally, allowing space for their feelings, and even providing opportunities for play, right back to child life.
Absolutely.
Yeah.
Understanding grief itself is also crucial for us. The material touches on various theories, including Kubler-Ross's well-known stages: denial, anger, bargaining, depression, and acceptance.
And it reminds us that people move through these stages very individually, not necessarily in a neat linear order, and they often bounce between them, right?
Totally. It also mentions anticipatory grief, which is really common when families have a terminal diagnosis. They begin grieving the loss before it actually happens, preparing emotionally. It's perfectly normal for different family members to be in different stages of grief simultaneously, too.
And something important to acknowledge, I think, is that staff grief is also a very real and normal part of this work. Caring for a child who is dying takes a significant emotional toll on nurses and the whole team.
Absolutely. It requires acknowledging and addressing that grief for the well-being of the staff themselves. So as we support families through their grief, we also need to educate them about the dying process itself.
The material notes that dying can often be a gradual and peaceful process with the right care, and those last hours and days are incredibly sacred moments for the family.
Right. Our role is to educate the patient, if developmentally appropriate, and the family about what to expect. For the patient, it might be about the cause of death, current interventions, and what the process of dying might feel like for them in simple, honest terms they can understand.
And for parents and caregivers, the education is usually much more detailed, covering more ground.
Yes, explaining how the disease is progressing, treatment options and potential outcomes, the expected time frame, and crucial changes to anticipate as death nears. Things like spending most of their time asleep, potentially still hearing, even if unresponsive.
Hmm.
Physical changes like mottled or cool skin, swelling, changes in breathing patterns, maybe Cheyne-Stokes respirations, and altered consciousness.
And what to expect at the moment of death, how the child might look, who will be present from the staff, who can be present from the family or friends.
Discussing cultural or religious considerations for handling the body after death is also vital preparation, and inviting family involvement in the final care, if they wish, holding their child, bathing them, simply spending quiet time, can be incredibly meaningful and healing.
And creating mementos, that seems like such a tangible way to hold on to memories during such an intangible time.
It really is. Simple things like handprints or footprints, maybe molds or inked prints, a lock of hair. Pictures, and many hospitals have resources for this, sometimes even volunteer photographers who specialize in this, keeping the child's name banned. These become treasured connections later on.
And then educating them on what happens immediately after death, hospital protocols for declaring death, disposition of the body, contacting the funeral home, and maybe discussing the possibility of an autopsy.
Yes, walking them gently through those practical next steps. Okay, let's touch on a couple of specific end-of-life scenarios outlined. Withdrawal of care.
Right. This is when the family makes the incredibly difficult decision to stop life-sustaining treatments, allowing the child to die naturally with family present, rather than attempting resuscitation by staff.
Parental rights are absolutely paramount here. They provide consent, they determine when interventions stop, and they absolutely have the right to change their mind at any point. Education is essential for everyone involved, parents, siblings, and, if appropriate, the patient on what this process entails and what physical changes to expect as the body naturally shuts down.
And during withdrawal, our nursing interventions shift entirely to comfort and creating a peaceful, private environment.
Exactly. Turning off monitors if they're distressing the family, disconnecting lines, ensuring the room is quiet, undisturbed, and private for the family to just be together in those final moments.
Another scenario mentioned is family presence during code situations or resuscitation attempts.
Yeah, hospital policies on this vary widely. The material points out the potential benefits families see everything possible was done. It can enhance communication, maybe reduce confusion about what happened.
But also the obvious potential negatives, witnessing their child at their most critical state, the intensity, the potential for interfering with the rapid interventions needed during a code.
Though interestingly, research does seem to lean towards supporting the benefits when it's managed safely. Our crucial role as nurses, if family is present during a code, is safety above all.
How so?
Assigning a staff member solely to stay with the family, ensuring they are out of the way of equipment and staff movement, especially during critical things like defibrillation, and providing them a place to sit slightly away from the bedside chaos, expanding things calmly if possible.
Got it. Okay, moving into the time after death documentation, organ donation, and legal aspects. Continuing to involve families in final care, like bathing or dressing if they wish, and ensuring those mementos are created remains important here, doesn't it?
Absolutely. And proper documentation at the time of death is critical. Everything done. Any interventions, the time of death, who was present, and the outcome, especially if resuscitation was attempted, must be thoroughly and accurately charted.
Organ donation is another possibility that might arise.
Yes, if a child is a viable candidate, meaning their organs are not damaged by their illness or injury, an organ donation team, usually separate from the primary care team, will approach the legal guardian. Consent is absolutely required. Blood is drawn for matching purposes.
Something that really stuck with me from the material is that the procurement, the actual organ recovery, happens in the operating room by a specialized surgical team, and the child technically dies there. The family cannot be present for that final moment in the OR.
That is a very difficult detail and a crucial one that families need to understand clearly if they're considering donation. The family is educated that the child will be kept stable on support until the surgical team arrives, that the death occurs in the OR setting, and they're often told about the profound benefit their child's donation will have for another life or multiple lives.
And the material mentions Optinino oversees the National Distribution Network.
Yes, the Organ Procurement and Transplantation Network, coordinated by the United Network for Organ Sharing. They manage the 2147 system to ensure fair distribution based on medical need and matching criteria across the country. It's generally a closed process. The donating family doesn't typically know the recipient family, though sometimes communication can be facilitated later through the organ procurement organization.
And a really important cultural competency point here. Understanding the family's beliefs about organ donation before even notifying the approach team, that seems vital.
Absolutely paramount. Respecting the family's cultural and religious beliefs comes first. Some cultures or religions have strong beliefs that might preclude donation, and that must be honored without judgment.
Okay. Finally, legal aspects are woven throughout all of this care. We have a responsibility as nurses to understand our state nurse practice acts and how legal considerations impact care.
Things like determining the legal guardian right on admission, understanding state laws regarding minor consent and emancipation, involving social work if there's any lack of clarity, and documenting all of that clearly.
Consent from legal guardians is needed for all procedures, right? Including withdrawal of care and organ donation.
Correct. And understanding DNR orders, do not resuscitate orders, is non-negotiable.
Respecting a DNR order is crucial, always following facility policy. Only legal guardians can determine or reverse a minor's DNR status. And we have to know the specific limitations within that order. Is it full DNR? Are some interventions okay, but not others?
And is your responsibility as the nurse caring for that child to know their code status and ensure it is clearly communicated and followed by the entire healthcare team. No ambiguity. Autopsies are another legal consideration.
Right, they can be requested by the family, the physician, or sometimes the coroner or medical examiner. Policies vary by state and facility.
The coroner or medical examiner usually has the legal right to request an autopsy in cases of suspicious or unexpected deaths, even without family consent. It's also good for families to know they may be responsible for the cost if an autopsy is requested by them and not legally required.
And the material highlights the extreme importance of knowing facility policies and state laws regarding suspicion of abuse, adhering strictly to IPA regarding information release, and ensuring meticulous documentation in those highly sensitive situations.
Yeah, the legal aspects really underscore the complexity and the immense responsibility involved in pediatric end-of-life care.
Okay, let's try to tie some of this together with a clinical judgment scenario from the material. We have an 8-year-old boy with terminal glioblastoma, a type of brain tumor. He's experiencing developmental regression and pain. He has a large family present, and his parents primarily speak Mandarin.
Okay, first question. What's the most appropriate pain scale to use for him?
Given his age, 8 years old, but also the potential developmental regression due to the tumor, we'd probably consider the FACES scale first, or maybe the VA-SOBS, the 0-10 scale, but only if he's developmentally able to understand and use it reliably. And we'd rely heavily on parent input and our own observations, like using the FLACC scale, perhaps.
Good points, exactly. Who would the child life therapist typically work with in this situation?
Well, the material makes it really clear they work with both the patient and his siblings, helping everyone understand and cope at their own level.
Correct. How do you best communicate with the Mandarin-speaking parents? And crucially, is it okay to use the patient or maybe older siblings to translate complex medical information?
Oh, absolutely not okay to use the children. Definitely not. We must secure appropriate professional translation services, either in-person interpreters or certified phone video services, to ensure accurate and sensitive communication. Using family, especially kids, is inappropriate and unreliable.
Spot on. What Kubler-Ross stage of grief might the parents be in if they're asking about when he can return to school or maybe start soccer practice again?
That sounds like it could be denial, maybe. Or perhaps bargaining, trying to hold on to normalcy or find a way to negotiate or change the devastating outcome.
Yeah, that's a classic presentation, isn't it? If the child is refusing pain medication because it makes him too sleepy, What alternative non-pharmacological therapies could you suggest to the parents to help manage his discomfort?
Okay, we could definitely explore massage therapy, maybe gentle relaxation techniques like playing soothing music or just quietly holding him, therapeutic positioning, and maybe some form of play therapy like quiet activities such as puzzles or coloring if he's able and interested.
Great options. And finally, how do you respond compassionately but appropriately to an aunt who comes to you asking about bringing in some special homemade food for the boy and also wondering if their spiritual leader can visit the bedside?
Okay, for the spiritual leader visit, we would absolutely facilitate that, contacting pastoral care if needed, or just coordinating with the family and the unit to make sure the visit can happen respectfully. For the homemade food, that's trickier. We'd have to gently explain that we need to check the facility policy, as rules on outside food vary widely due to infection control or dietary restrictions. We'd acknowledge their loving intention while explaining the policy compassionately.
Perfect. That case study really brings home how all these pieces, communication, the team, comfort measures, cultural awareness, family dynamics, they all converge in real life practice, don't they?
This deep dive has covered so much vital ground. From the fundamental importance of compassionate communication with families and the healthcare team, to understanding the distinct roles of palliative and hospice care teams, mastering pain management using appropriate tools, and both pharmacological and non pharmacological interventions.
Yeah, and we've explored honoring cultural and religious needs, navigating the complexities of grief and how children understand death at different stages, educating families empathetically about the dying process itself, managing specific challenging scenarios like withdrawal of care and family presence during codes.
And covering the crucial practical and legal considerations, from creating lasting mementos to the sensitive processes around organ donation, understanding DNRs and their implications, and the absolute importance of thorough documentation throughout.
It truly highlights the vital, multifaceted, and profoundly human role you will hold as a nurse, providing care in these incredibly intense and intimate moments. It's challenging, it's essential, and it requires incredible heart and skill.
It absolutely is, and it's a topic that it stays with you. Here's a question to leave you with, something maybe to reflect on as you move forward. Given the intensity of this type of care, what practices or rituals might you incorporate into your own routine, or even just your mindset, to ensure you are also caring for yourselves while supporting families through their deepest grief? How do you sustain yourself in this work?
Hmm. That's something incredibly important to consider as you prepare for this demanding but ultimately very rewarding work.
Care with heart, always. See you next time.